I'm absolutely delighted that Professor Sir Munir Pirmohamed has come to give us an overview of clinical pharmacology in the NHS. And we're incredibly lucky to have Munir in the specialty fighting for us to have our place in the NHS and to move forward as a specialty. So thanks so much, Munir. Before I embarrass you any further, please come and tell us about clinical pharm in the NHS.
Good morning, everybody. So clinical pharmacology has always been a small specialty. But there's no doubt that we've always punched above our weight, and this is shown by these famous 6 clinical pharmacologists. Many of them are still very active, despite their maturity, let's say. But we shouldn't really rest on our laurels. We can't be complacent. And things are moving on rapidly in medicine and in other specialties, and we need to move along with the times to make sure our specialty remains at the cutting edge and remains influential. However, there are some challenges, but there are also opportunities. And what I want to do is to tell you about some of the challenges and what we're trying to do within British Pharmacological Society to try to overcome those challenges. And you'll hear a lot about things today from Emma and various other people in terms of what's going on. So when I started as clinical vice president for the British Pharmacological Society, one of the things I said was, well, we need to determine what's going on with clinical pharmacology in the country. Why, how many posts do we have? What can we do to be able to increase numbers of posts? And when we did a survey at that time, we found that there were about 77 clinical pharmacology consultants. The RCP recommends we need 440. But we then did an exercise. We said that we probably would never be able to get to 140, but what we wanted was about 150 clinical pharmacology consultants with an equivalent number of trainees. So that would require an expansion of the clinical pharmacology workforce by a factor of 2. But the interesting thing was that if you look at clinical pharmacology expansion, and that's the green line there was only a very small expansion in clinical pharmacology over the years from 2002 to 2012. Yet, if you look at the other medical specialties, there was a massive expansion. So while other medical specialties have expanded a great deal from 2002 to 2012, clinical pharmacology didn't really expand very much. And that was a cause for concern, and that is when we started some of the work that we've been doing, and I'm going to go through what has happened in that time. Those data were from 2014, and it's very difficult to get data because everybody says, well, there's data protection now, there's GDPR, so nobody wants to give you any names and numbers and things like that. But anyway, there's sort of a Royal College of Physicians now has does a census and has a dashboard, and you can get these things from the dashboard. And you can see what the numbers of consultants are, and it seems to be going up, but not hugely compared to other medical specialties. And you can see where they're located in the country. Obviously, the problem with the census is that if you don't answer the census, you don't get counted. So it may be inaccurate in that way as well. But if you can see that London is the best served for clinical pharmacologists, followed by Scotland, etc., and so on. So there is quite a lot of disparities in terms of numbers of clinical pharmacologists throughout the country. Some areas of the country, such as the West Country, Southeast, etc., don't have very many or hardly any clinical pharmacologists at all. And we need to think about how we can increase numbers of clinical pharmacologists throughout the whole of the UK. Clearly, there aren't enough clinical pharmacology academic units in all of these different areas of the country. So one way to be able to increase the numbers of clinical pharmacologists in all areas is to actually embed them into the NHS, because there's an NHS trust in every part of the country. And how do we do that? And that's what I really want to talk to you about a bit more, and some of the work that's going on. And Emma is going to present a lot of the work that she's been doing and leading, which has been fantastic. So why has there been a lack of growth in clinical pharmacology? And I think there's 3 main reasons over the years since 2002 why we haven't had such an expansion compared to other specialties. The first one is changes in the NHS. NHS is changing all the time. We've got a 10-year plan coming up very soon. There's new money coming to the NHS, but we have enormous pressures. And in the 1990s and then 2000s, the NHS started doing things differently, and trusts were particularly paid based on procedures that were undertaken, the tariff-based payments. Now clinical pharmacologists don't undertake procedures as such, but save money by reducing drug costs and so on, and that was not good enough for trusts and so on. They'd rather employ somebody who did lots of procedures and brought in money in that way. So that led to preferential recruitment of people who did procedures compared to clinical pharmacologists was one particular area. Academia, we had the research assessment exercise coming through at about the same time in the late 1980s and the 1990s, and now it's called the Research Excellence Framework. And clinical pharmacology as a whole didn't perform very well in the research assessment exercise because much of the work that was undertaken at the time, which is mostly PK/PD type work, wasn't seen as very high impact, didn't appear in Nature and things like that. However, that work is hugely valuable and has impact. The new Research Excellence Framework now doesn't just focus on your outputs in terms of 4-star papers, it also focuses on impact studies. And some of the things that clinical pharmacologists are doing in terms of impact really is there's an opportunity to really embed that into the Research Excellence Framework and show impact in the medium term and in the long term, and working with industry, but also actually bringing things into the NHS in terms of guidelines. So I think there is an opportunity there for academia and in terms of Research Excellence Framework as well. And the final thing I think that happened was the introduction of problem-based curricula throughout most of the country, which meant that clinical pharmacology and pharmacology wasn't really taught to medical students to any great degree, and the ologies were not fashionable. However, that's now reversing, and there's much more teaching in the ologies within curricula now. So I think things are improving, but we need to then focus in on the NHS and how we can really try to embed clinical pharmacology with the NHS. And clinical pharmacology careers are varied, and then obviously these are the 4 different main areas that clinical pharmacologists work in. There are other areas as well that clinical pharmacologists work in. Clearly, if you are working in the NHS, you can also be working in academia and vice versa. Some people work in academia, NHS and regulation, and some people work between industry and academia as well. So you can have a varied career, a portfolio career if you like, which allows you to be able to do all of those different things at different times. And that's the important thing about clinical pharmacology, I think. It brings the strength, it's a strength to clinical pharmacology. I think I would hate, and I know that you're filming me, but I hate to do catheters for the next 30 years, every morning, or look up, in colons and so on for the next 30 years. You should be doing something different every day, and that's what allows, clinical pharmacology allows you to do that. So what we've been trying to do is to really highlight the value of clinical pharmacology. And as part of the work that we've done with the British Pharmacological Society, and British Pharmacological Society has been fantastic in supporting all this work, is first of all to produce several reports, and 3 of them are shown here, which showed how valuable clinical pharmacology is in different parts. So the first report, Prescription for the NHS, was launched in the House of Lords with the help of Robert Winston. We also had partnership arrangements with the ABPI showing the value of clinical pharmacology and experimental medicine and so on. And the most recent report was talking about economic benefits. And this was done with PricewaterhouseCoopers. And basically this report said that for every £1 invested in clinical pharmacology, the NHS would save £6 through the efficient use of medicines. And you can see that would equate to 1,600 extra nurses and 600 extra doctors. And clearly that is an important statistic, and we need to use that every time we're making a case to the NHS for more posts in clinical pharmacology at trainee level or at consultant level. We need to carry on doing that. Now, when we did the work, there are 6 domains we identified where clinical pharmacology can be important with regard to what it does in the NHS. Clearly, care provision is very important. Seeing patients is always going to be very important, and clinical pharmacologists have to be there right at the front end, seeing patients in different specialties, but also in the clinical pharmacology work arena as well. I'll come back to that. Clinical toxicology, obviously most clinical toxicology units are run by clinical pharmacologists, it's a very good service and well recognized to be a good service. Experimental medicine. Although not all CRFs are run by clinical pharmacologists, many are, and we need to become embedded in that. And there is a big need for more experimental medicine going on in the NHS. Phase 3 and Phase 4 trials in this country are really expensive, much more expensive than most pharma companies can get in developing countries, in other parts of Europe, but also in China. And so, but what we can do in this country is really have the infrastructure to undertake the early phase trials. And I think there's a big growth area here that we need to take advantage of. And there's a need for more people trained in experimental medicine as well here. Working with industry, I'll come back to that with life science strategy, and clearly education training. And that is really important. And as I said, that is now becoming much more important with regard to prescribing competencies and the work that's been done by BPS, Simon Maxwell, and various other people in this room. So clearly our role is in terms of medications and medicine safety, medicines policy, and you can see the kind of different things that occur within the NHS and huge amounts of money that's spent on medicines in the NHS. So £18 billion a year was the annual budget last year for NHS England, just NHS England for the drugs, which were sort of for the drugs bill, and there is a huge amount of wastage going on in the NHS in terms of drug costs, drug adherence issues, medication errors, adverse drug reactions, and it's good that I got this slide from somebody from NHS England, and you can see that they use some of the data that we created in terms of the 2004 study I did for adverse drug reactions and admissions. And the top 5 drugs are the old drugs which have been around for a long time, and these are still the commonest causes for adverse drug reactions causing admission to hospitals and so on. So here is an area in terms of medication safety, medicines optimization, and with the polypharmacy coming along, where clinical pharmacology can really play a role in the NHS. And what we're facing is a change in demographics, with the numbers of people over the age of 65, 75 increasing massively. But it's not just the age change which is going on. There's a change going on in terms of numbers of diseases people have and so-called multimorbidity. So the Academy of Medical Sciences has produced a report which says that multimorbidity definition should be more than 2 chronic diseases in patients, and that's now been accepted as a definition, a standardized definition. And when you look at what's going on with ages, even at younger age groups, you can find patients with multimorbidity. Even at the age of 50, people may have multimorbidity. And as you get older, you can see the numbers of people with multimorbidity that is being seen within the NHS. The problem that we have in the NHS is that we were all trained on the basis of particular disease areas or particular specialties. So medicine is very compartmentalized in the NHS. Yet sometimes we see patients with 4 or 5 diseases at the front end in accident emergency in the acute medicines unit. And most specialists or organ-based specialists will just focus on those particular disease and then refer to somebody else to look after the other organ system. But a clinical pharmacologist can actually look at all those different diseases at the same time in a holistic manner. And I think there is a huge advantage of clinical pharmacology being able to be right in there dealing with the multimorbidity issues that's coming up with NHS in terms of clinical care, in terms of research as well. And clearly associated with that is a polypharmacy issue not only associated with multimorbidity, but polypharmacy generally. And Emma will be going through that in more detail in the next talk. There's an issue of de-prescribing. There's a big agenda for NHS England at the moment in terms of de-prescribing. There are many tools out there. Here's one which is called the No Tears tool. And there are other tools as well for de-prescribing. But everybody, we have so many different prescribers in this country now, because there's the non-medically qualified prescribers, but nevertheless still playing a very important role. But the problem is that if you've got so many different prescribers, in different parts of the NHS, there's often a tendency to start the drug, but it's very difficult to stop a drug. Because people say, well, I don't want to stop a drug because it was started by this consultant or whatever. And so patients keep on going up in the numbers of drugs. And we frequently are seeing patients with 15 drugs, 16 drugs in clinic. And that really can't continue. How many patients on 16 drugs will be taking their drugs regularly? Very few of them. And I just remember a case of a patient who I saw in clinic, came in on 17 drugs, was referred to me with hypertension, and was on 7 antihypertensives. He was on the beta blocker, his heart rate was 92. I said, are you taking your drugs? He said, yes, absolutely. I've got a Dorset box, morning, afternoon, evening, and bedtime. I take them regularly. So I said, okay. So, but I was very suspicious, so I measured the drugs and found that I could not detect any drug in his urine apart from caffeine. He liked a cup of coffee. So honestly, there are many patients like that out there, and we really need to think about that in terms of trying to improve the issue of numbers of drugs patients are taking. A big opportunity for us, I think, is also with what's going on with the life science industrial strategy. This has been produced as a result of the Brexit issue that's going on at the moment. Irrespective of what happens with Brexit, I think it is going to be really important for us to be able to interact with industry in some way. And the life sciences industrial strategy, which was produced a couple of years ago, and the second wave has just been published, highlights the need for clinical pharmacology, highlights the needs for better skills in the NHS across working with the commercial and academic sectors. Highlights the need for clinical pharmacology, highlights the need for regulatory skills and innovative regulation, so that we have regulation which is not overburdensome, it is proportionate, so that it does not stifle innovation. And that's hugely important, I think, as well as we move forward. And you can see that the need to, what they highlighted was the need to develop regulatory standards, standards for emerging technologies. There's hugely emerging technologies coming through, etc., which are also potential opportunities for clinical pharmacology. So as part of the industrial life science strategy, what the BPS has been doing, working with many of you in this room, but also with other people outside, is to we've developed something called the Clinical Pharmacology Skills Alliance. And this is really a partnership between Health Education England, the Association of British Pharmaceutical Industry, and the Faculty of Pharmaceutical Medicine. And the one thing that we've tried to do here is to highlight that clinical pharmacology is not just restricted to medically qualified clinical pharmacologists. We need to go beyond that. There has been a tendency to say, well, it's only medically qualified people can be called clinical pharmacologists, but we need to go beyond that. Clinical pharmacologists can be non-medically trained, can be come in from a science background and be hugely valuable to both the NHS and industry, and I'll come back to that. So I think we need a broader definition of clinical pharmacology. Even if we manage 150, there's so much to do with regard to medicines and NHS. There's no way the 150 of us can really tackle all the medicines issues. So we need to work in partnership with other people to take things forward for the NHS. So we've, working together, have created an action plan. I'll go through that in a minute. And the Alliance is really committed to seeing through a long-term cross-sector action plan that will hopefully change the sort of infrastructure, change the sort of funding environment, etc., and change the numbers of clinical pharmacologists in this country. And this is a very complicated schematic of clinical pharmacology training pathways. So you can see the top end is where the medical training pathways, and this is where most of you will be in this room in terms of going through. You may be just going through your STER programs. Some of you may have taken time out to do a PhD from having had a clinical training fellowship, and then going through to your consultant senior lecturer positions. Then at the bottom is the new scientific training pathway, where you come in with a BSc, have a PhD, can be postdoc, or you can come in other areas, and then what you can do in terms of the different potential clinical pharmacology roles. And you can see the clinical pharmacology roles have been divided into 4 areas: NHS, industry, academia, and regulation. It can be in healthcare, it can be clinical research, it can be in industry, drug discovery, development, in medicines regulation, and also in education training. And the scientific training pathway can be involved in all of those, apart from directly seeing patients, unless the clinical pharmacology trainees scientists go and do physician associate schemes and so on, and qualified physician associates as well. So there are 4 strategic objectives. So first one is to understand how clinical pharmacology skills deliver for patients, life sciences, and NHS. So that we need to develop partnerships, develop an integrated medicines pathway, etc. We need to communicate, really very importantly, with sector leaders to show why clinical pharmacology is important for the NHS and academia, and that's going on at the moment. We need to develop high quality, integrated, streamlined training experience for clinical pharmacologists across the whole landscape. And clearly some of you have been involved in developing the training charter for clinical pharmacologists. One of the issues that we had from the surveys that are undertaken is that many of you are being asked to do a lot of general internal medicine without getting much time for clinical pharmacology training. And we're trying to reverse that so that you do have good time for training for clinical pharmacology. Number 3 is to promote awareness and access to clinical pharmacology training careers. I think Emma calls it the white rhino syndrome. We are not visible to medical students, we're not visible to junior doctors. And how do you develop that engagement at the sort of front end, where medical students are entering training, junior doctors are coming in and deciding on their specialties, to show that clinical pharmacology is a worthwhile career. And clinical pharmacology of the month scheme, clinical pharmacology month scheme, which many of you have been involved in, is part of that. And we need to make sure that is going through in future years, perhaps with a different focus. And also the 4th objective is to recommend short-term investments in clinical pharmacology skills to help the most pressing challenges. And that's part of the work that's going on with the life sciences strategy, etc., so that we can actually try to improve numbers of clinical pharmacologists in different areas. But the biggest challenge and the biggest issue that we need to really convince the government, convince NHS England, convince Health Education England, is to increase the numbers of trainees, which we're trying to do, and increase numbers of clinical pharmacology consultant posts throughout the country. And that's going to be number 4, and that's going to be the biggest and most pressing challenge, and most difficult challenge that we need to be able to meet. So one of the areas where we've already had success and work undertaken by Anna Zakaria, which has been really important on her team, together with many other people involved in the CPSA, has led to the development of this clinical pharmacology science apprenticeship scheme. It's already advertised at the moment on the Institute for Apprenticeships. And this is really to develop the clinical, non-clinical scientific route into clinical pharmacology, and really so that these clinical pharmacology scientists can work in the public arena or in the private sectors, and will be able to undertake many different things, such as in clinical trials, optimize PK/PD, undertake dosing recommendations, etc. I had a chance to review what was going a hospital in the United States, St. Jude's Hospital in the United States, which is a children's hospital, fantastic research hospital, and what the pharmacists do there, and they call themselves clinical pharmacologists, is absolutely amazing. They undertake the PK/PD work, they work with the medically qualified clinical pharmacologists, and really determine what goes on in terms of testing, as well as when you need to have therapeutic drug monitoring done. And we need that kind of work going on throughout the whole of the NHS, working in partnership with pharmacy. And it is really important that pharmacists and clinical pharmacologists work together. I think there's been a bit of tension in the past between the two professions. And when we first launched our report in the House of Lords, there were lots of negative tweets about clinical pharmacology and pharmacists. But Anthony Cox, who's a pharmacist in Birmingham, said the swamp of medicine-related problems is vast. Neither pharmacy nor clinical pharmacology is going to drain it alone. But at least we can work together to fix the parts we can. And that's really important, that we do need to work together with pharmacy. And that's important, and you'll hear that throughout this conference and with Emma's workshop about partnership working in terms of going forward. There are other opportunities for clinical pharmacology coming through as well, and you are the people who are going to have to really see whether these are opportunities for you. I think pharmacogenomics and precision medicine is an opportunity. There is going to be implementation of pharmacogenomics in the NHS over the next year, and you are going to be at the forefront of it. Artificial intelligence and how artificial intelligence is being used in the NHS. There's a big drive towards that, and I think that's really an opportunity for clinical pharmacology, right from the front end to drug development, right through to pharmacovigilance. And there are a lot of work going on in that area. Big data, the big data revolution that's going on at the moment. And I ask people, do you know what the definition of big data is? Most people don't know. So go and look it up, what the big definition of big data is. But it requires velocity, veracity, volume, and value. 4 V's. Okay, and that's the definition of big data. Biologics, advanced cell therapies. Unfortunately, most clinical pharmacologists are not dealing with biologics. Very few are. I think that's a real niche. So if anybody of you are interested in that, that's a real niche for you to be able to go into. And the advanced cell therapies, gene therapies that are coming through, some fantastic advances which are going out there. But there's a need to be able to understand how to test them out in early phase trials, and clinical pharmacology could really have a niche there. And finally, there's regulatory science, and that's really important as well in terms of future clinical pharmacology training and an opportunity of clinical pharmacology. And clearly, education training and the success of the prescribing safety assessment is hugely important. So I think there is a burnout going on amongst doctors, and there's a lot of concern about burnout in the NHS. Most people retiring early, largely because they're just fed up of what's going on in the NHS. But I think from personal reflection, I think I do something different every day. I never get bored. I think that's one way to avoid burnout, actually. Because if you are doing colonoscopies for 30 years, I'm not surprised you burn out, actually. Okay, so just to finish off, I think there are challenges, but I think we can turn those into opportunities for clinical pharmacology working in the NHS. We need to show our value proposition. What is unique about ourselves that makes us really important to the NHS? And I think we're trying to do that with the work that's going on with the CPSA, but you need to be involved in that work and show how we can really have a value proposition for the NHS. And we can't do this in isolation. Even if there are 150 of us consultant-wise and 150 trainees, we are still a very small specialty. We need to work in partnership with other specialties, with pharmacy, with computer scientists, data scientists, etc., so that we can actually show the value of clinical pharmacology. So thank you very much for your attention.